Hi all, I'm Dr. Shivangi Tetarbe. I'm excited to start a new series on Pediatric OnCall focusing on inborn error of metabolism. In this series, I'll simplify this complex and often overwhelming topic by breaking down the various types of IEMs, their symptoms and clinical approach, all presented through easy to follow 10 to 15 minute slide based sessions. IEM is known for its complexity with numerous flowcharts scattered across literature. My goal is to provide you with a clear practical approach that you can readily apply in everyday clinical practice. So in this session, I'll be focusing on how to identify inborn error of metabolism in a newborn. So let's begin with the question, what is IEM and is it really rare? So IEM is a group of disorder resulting from deficient activity in enzymes in metabolic pathway. Individually, they are rare indeed, but collectively overall incidence increases. There are more than 500 IEMs recognized currently. Why does it matter to identify an IEM in newborn? So symptom often appears within first few days to few weeks of life. Early detection is critical to prevent serious complications, including brain damage or organ damage. Few are easily treatable with medicines or dietary formula modification. Identifying inborn error of metabolism is crucial not only to determine the prognosis in the affected child, but also for guiding management in further pregnancies. So, what are the possible presentations of IEM in neonatal period? There can be non-specific signs which usually mimic sepsis. It can be poor feeding, lethargy or irritability, vomiting, hypothermia or temperature instability, respiratory distress or apnea. Neurological symptoms could be hypotonia, seizures, altered level of consciousness or encephalopathy. There can be metabolic changes in form of unexplained metabolic acidosis, hypoglycemia, hyperammonemia, lactic acidosis, ketosis. Other clinical clues could be jaundice or liver dysfunction, unusual urine or body odor, failure to thrive, and dysmorphic features in some cases can be there. Always consider IEM in any sick newborn with unexplained symptoms, especially when sepsis screen is negative. So, the usual indication for admission to the NICU often overlaps with the symptoms of inborn error of metabolism, making diagnosis and treatment pretty complex. So, what are the differential diagnoses of IEM in neonatal period? It can be sepsis-like presentation, neonatal sepsis or meningitis, or congenital infections of torch. Metabolic acidosis or encephalopathy can be the other differential. Due to birth asphyxia, HI, intracranial hemorrhage, severe hypoglycemia, due to non-IEM causes like maternal diabetes or insulin overdose, and electrolyte imbalance. There can be hepatic dysfunction or coagulopathy due to GALD, which is gestational alloimmune liver disease, neonatal liver failure, which can be non-metabolic causes like HSV and HLH, biliary atresia early onset. Hypoglycemia can be documented due to congenital hyperinsulinemia, adrenal insufficiency, and endocrinopathies including hypopituitarism. Dysmorphism or developmental anomalies can be there, like chromosomal abnormality, trisomy 13-18, or syndromic genetic disorders. Always rule out more common causes first, but keep IEM in mind, especially when routine workup is inconclusive. So once you see a sick child not responding to conventional treatment and the labs are not fitting into any of the common diagnosis, you start taking additional history. So you need to ask top feeding just to know if there is any, it can be a cause of sepsis, or sometimes some metabolic disorders do present after initiation of feed. You have to ask for seizure, episodes of hypoglycemia or irritability, hypotonia, poor sucking or refusal to feed. There can be bloody stools or loose stools, reduced urine output, jaundice or clay color stools, persistent vomiting. If there is any improvement or deterioration after switching of formula, excessive hiccups. What key antenatal and family history elements are relevant when evaluating a possible inborn error of metabolism? So, history of multiple miscarriages in mother, hyperemesis extending the first trimester, acute fatty liver of pregnancy and features of HELP, which can be due to LCHAD or fatty acid oxidation defect, non-immune hydrops, which can be seen in congenital disorders of glycosylation, MPS type 7, history of consanguinity, previous sudden infant death, positive family history or inheritance pattern, like only males affected in the family, or it's a maternal inheritance, poor fetal movements or polyhydramnios in fetal period. It could again be a sign of congenital disorders of glycosylation or GSD, that is glycogen storage disease type 4. So what are the clinical clues in newborn? What do you need to watch for? So general appearance, you have to look for lethargy, poor feeding, hypotonia. Vital signs, you have to check for temperature instability, respiratory pattern. In neurological examination, you need to check for seizures, altered tone or consciousness. In skin, you have to see for rashes, jaundice or unusual odor. You have to check for organomegaly and any dysmorphic features. These findings, though, are non-specific, but can be key early indicator that points you towards considering IEM in your differential. After examination, which initial laboratory test you want to order? So it should be CBC, definitely, to rule out sepsis. But in certain IEM, you have specific hemogram findings, like neutropenia can be seen in organic acidemias in GSD type 1b. Thrombocytopenia can also be seen in organic acidemias in GSD. You have to send septic markers, which includes your CRP, your peripheral smear for toxic neutrophilic granules. It also includes your procalcitonin. In some centers, it can be easily done. Blood culture, urine RM, stool RM if flu stools are there. So septic markers has to be done, and CSF analysis if any neurological symptoms are there in form of encephalopathy or seizures. Arterial blood gas and electrolyte is mandatory, as there can be high anion gap metabolic acidosis in organic acidemias. Blood glucose has to be checked. Plasma ammonia is important. Arterial blood lactate is important, especially for diagnosis of FAODs, mitochondrial organic acidemias. Liver function test has to be done, especially if we suspect gall, if child looks jaundiced, or you find organomegaly on per abdomen examination. You look for galactosemia, congenital disorders of glycosylation, tyrosinemia, mitochondrial disease, UCD and lysosomal storage disease. You have to check for ketones, urine ketones, and urine for reducing substances. Urine for reducing substances is for galactosemia. In older children, that can be done for hereditary fructose intolerance. Serum uric acid, low, where you will find it will be low in molybdenum cofactor deficiency. Additionally, what investigation can be done? So CSF analysis, ophthalmology for any signs of metabolic liver disease, uveitis, cherry red spots, cataracts, 2D echo for any cardiac defects, USG abdomen and KUB to look for the status of liver, pancreas, spleen, kidneys, and neuroimaging if at all there is any neurosymptoms. So now when you have taken history in detail, you have examined, you have taken family history and birth history, what would you want to do? Now from at this point you are thinking of IEM definitely. Then do you want to go ahead with genetic testing, or you want to run certain more tests? So here I would say that you should send genetic testing right at the point when you think of it as IEM, but simultaneously you will have to send other tests, because genetic testing is not only costly but also the turnaround time for the reporting is at least 4 to 6 weeks. So it's very important to start at least giving the blanket treatment to the patient to prevent the damage as much as possible. So what test we can do, which is easily available and TAT is low, that is your TMS and GCMS, which picks up your organic acidemias, your urea cycle defect, amino acidopathies, fatty acid oxidation defects. You also have to send HLH workup, which includes your CBC, ferritin levels, fibrinogen, triglyceride, bone marrow biopsy. You have to send GALD workup, which includes transferrin saturation, ferritin levels, MRI T2 star for extrahepatic iron deposition. We can also do buccal biopsy if needed. We have to send viral markers, which is especially HSV. Galactosemia workup we can do, in which we can do blood sugars, fasting sugars especially, urine reducing sugars, GALT assay. We can also do serum galactose. Apart from that, we do MRI brain plus spectroscopy, especially in mitochondrial, non-ketotic hyperglycemia, MSUDs. CSF glycine levels can be sent for NKH. So what is the role of urine GCMS and blood TMS in diagnosing an inborn error of metabolism in a newborn? Urine GCMS detects volatile and semi-volatile compounds, mainly organic acids. Blood TMS is highly sensitive but not specific. Amino acidogram, organic acids and fatty acids in form of their acyl carnitine esterase can be tested in this. It does not screen for IEM such as mitochondriopathies, purine and pyridamine disorders, neurotransmitters, congenital disorders of glycosylation, and very long chain fatty acids. Although these are easily available and turnaround time for reporting is pretty less, usually within 5 to 7 days we get the report, again depending upon the centers. In setting of hepatic dysfunction, sepsis, multiple antibiotic use, there can be false positive reports. So here a high peak, usually we say 10 times the normal fold, a high peak is going to be significant, but borderline intermittent metabolite levels are non-significant. So now when we have done these tests, these reports may not be conclusive. We have already sent the genetic test, and if at all we are able to figure out which IM we are dealing with based on clinical examination history and biochemical plus radiological investigations, we wait for genetics. But it's not easy to interpret genetics always. Sometimes we happen to get certain weird reports which do not relate with phenotype. Sometimes we land up doing a reverse phenotyping, where we get a report and then we start looking into the patient if we have missed on some phenotypical findings. So there are multiple types of testing that can be ordered. There can be chromosomal microarray, which detects chromosomal abnormalities, usually helpful in syndromic IEMs. There is next generation sequencing, in which you have whole exome and targeted panel for IEMs. You can do Sanger sequencing. So it's usually helpful when we have an index case and the same gene mutation can be run in the family members or siblings. This is particularly helpful in VUS varieties. Other thing we have is whole genome sequencing. It's a comprehensive analysis of the entire genome. Then we have FISH, and lastly we have mitochondrial panel, which reads and assesses the mutation in mitochondrial DNA. It is useful for diagnosing mitochondrial disorders which may present as neurological, muscular and metabolic symptoms. It's very necessary to always give the symptoms, the phenotype and your differentials to the geneticist, because most of these panels or the NGS is run is on the the whole exome is run is not run over the introns. So sometimes if we specifically think or we emphasize on a certain diagnosis or differential, genesis can run the introns and see if there is any mutation on it. Genetic testing should be tailored based on the clinical presentation, and often a combination of tests is required for accurate diagnosis. Now, how do you interpret this whole exome sequencing? Both pathogenic mutations and variants of unknown significance, that is VUS, can be reported on the same exome sequencing. Even for the same gene, it can be there, or it can be different mutations or different diseases. Now, VUS, clinical significance for it is not yet defined. It may be related to the patient's phenotype and should be reported. Need for Sanger sequencing and functional study of the gene is usually there with VUS. Pathogenic mutations, they are already evidence-based, there is strong evidence in causing the disease. But the genomic variant, here the genomic variant are classified as benign, likely benign, VUS likely pathogenic, or pathogenic based on population data, disease association, predictive tool and clinical features. Interpretation can vary between labs due to the subjective nature of the evidence evaluation. VUS are more common than pathogenic findings, especially with large panels due to limited genetic diversity in database. As knowledge evolves, around 10 to 15% of VUS are reclassified as pathogenic, while most are downgraded to benign. Addressing VUS remains a key challenge in genetic testing, requiring often efforts in data interpretation and clinical correlation. Many VUS are unique to individual families, and family-based testing can help clarify their significance. Testing relatives can show if a variant is inherited or de novo. De novo variants are more likely to be pathogenic. In dominant conditions, broader family testing can reveal whether the VUS consistently tracks the disease, that is co-segregation, aiding reclassification. Widespread use of these methods could enhance reclassification of variants as pathogenic or benign, but would require comprehensive family counseling, and this also increases financial burden. So now coming to the red flags that you should notice in the patient while you're suspecting, or when you should start suspecting IEM. Because like I said, there are a lot of overlapping features. So the point where you should start thinking are the 10 points to be noted. A. The family history of unexplained sibling death. History of consanguinity. Encephalopathy and seizures after initial symptom-free interval. Persistent encephalopathy more than 1 week. Recurrent unexplained hypoglycemia. Normal, the baby was normal at birth and then became symptomatic later, probably after initiation of feed or within few days or few weeks of life. Unexplained metabolic acidosis. Non-immune hydrops of unknown etiology. Unexplained cardiac failure. Unexplained hepatomegaly, cholestasis or hepatic dysfunction. So when you see these things, then come down to a simple algorithm. There can be a significant ANC family history, or there can be no significant ANC or family history. If there is significant ANC or family history in form of consanguinity or previous miscarriages, similar history in the family, sudden child deaths, non-immune hydrops, etc., and child is sick, the newborn is sick, or the newborn has born sick, so think of IEM. If there is no such significant ANC or family history, child was non-sick to begin with and followed by sudden illness, think of IEM. No significant ANC or family history, child is sick to begin with but not responding to your conventional treatment. All the other factors including HIE, sepsis, everything is ruled out. Think of IEM. Once you start thinking IEM, you have to follow this mnemonic, GALIC. You have to send GALIC. GALIC is glucose, ammonia, or pH, that is your ABG, lactate, serum electrolytes and ketones. So this is the chart which we usually see in most of the textbooks. You have glucose, you have the episodes of hypoglycemia, if there is acidosis or alkalosis. If there is increase in ammonia or ammonia is in normal level, lactates are increased or normal, anion gap is high or normal, and ketones are there in urine or not. So when you come to urea cycle, you have a pH which is increased, that is it is alkalotic, and there's hyperammonemia. So usually urea cycle patients have a respiratory alkalosis due to hyperammonemia, while rest of the things are usually within normal limit. When you see amino acidopathy, there may not be hypoglycemia, but there is acidosis, a metabolic acidosis. Ammonia will be normal, lactate will be normal, anion gap will be high, ketones will be high. Coming to organic aciduria, again your hypoglycemia episodes are not going to be there. Usually your blood pH falls and goes for acidosis. Ammonia will be increased, lactate may be normal, may increase, anion gap is usually high, and ketones are increased. For fatty acid oxidation defect, usually there is severe hypoglycemia, recurrent episodes of hypoglycemia. There can be acidosis or pH can be normal. There can be hyperammonemia. Usually lactates are within normal limit. Anion gap may increase or may be normal. Ketones are usually less or low. For carbohydrate metabolism, there is severe hypoglycemia. Blood pH goes down, that is there is metabolic acidosis. There is also lactic acidosis in form of high lactate. Ammonia usually is normal. Anion gap is increased. Urine ketones are increased. Talking about electron transport chain, which is usually your mitochondrial. So there will be hypoglycemia, may not be there. Blood pH usually falls down to acidosis. Ammonia is usually normal. Lactates are pretty high. Anion gap is usually high, and urine ketones are negative. So this was the general approach to an IEM when in the newborn period or when the patient is admitted in an ICU. From here on, I'll be taking each of this classification in short and simple manner in different sessions. And then we can have a session then how to identify inborn error of metabolism in children who have crossed their infancy. So this is all for the session. Thank you.